bit about myself. I've been here around 20 years. I was a nurse before that also in Nashville, but I've been here doing this job for 20 years. And this in-service is something I've been wanting to do for a very long time. I do a lot of in-services in the hospital, but I've been wanting to do a community in-service for a long time because ostomy patients are very special to me. To also introduce Jeff. Jeff is our director of our DME company, or our medical equipment company here in Paris. It's called In-Home Supplies. And he actually brought you some pens and pencils back there and some things. So he's kind of here to help you with those reimbursement questions or questions about getting supplies for your patients. Because if you're coming from home health or the nursing home, sometimes it really depends when you're sending that patient home what kind of insurance they have, where they're going to be able to get their supplies and what kind. I actually had an ostomy about 18 years ago, and it was pretty emotional at the time. I don't know why I'm crying about it now. When you're sitting there and you're really sick and your doctor walks in and you're already an ostomy nurse and he says, "We're going to have to give you an ostomy." And I really thought he was joking. I actually said, "You're kidding, right?" And he said, "No, I'm not kidding." So I survived. It was a life-changing situation for me. I think that it's made me a better nurse. And Jeff is also an ostomy patient, and his is permanent. And he did say, I could tell his situation. But I think together we try to do a really good job for our patients of getting them what they need, because we've been there. We know what they're going through, we know what they're living through, and we know that it's not something simple as we do the surgery in the hospital, we send them home, and then everything's happy after that. We know they have complications. One of the things that I've learned a lot through the years is our ostomy patients are pushed out of the hospital a whole lot quicker, and so they may not get as much education as they used to. And I want them to be able to go to your facilities, whether it be home health or nursing homes and rehabs, and get some more education so that when they go home, they're a little bit more comfortable. Okay? So we're going to start first with my inspiration today. And if I turn it on, it works. So here's our inspiration. These are the Girls with Guts. And it is a little support organization, but I found the picture and I thought, this is what we're about as nurses. We're about changing people's lives, and these girls are proud of their ostomies. They're living with them, they're going through hard times, and they're young. Most of our patients here in this community are older with their ostomies, but this should be an inspiration to all of us on how to live with an ostomy. So colostomies are the first thing we're going to talk about. There's lots of different kinds of ostomies. If you find out that you're going to have a colostomy or a patient with a colostomy, you can hope that this is one of the easiest ones to take care of. Okay? One of the reasons it's easier to take care of is their stool's going to be a little bit thicker. It may be thick to even formed at times. They shouldn't have to empty it maybe 1 to 2 times a day when they start getting back to normal after surgery. So it's a little bit easier to take care of. And when you go in to see your patient, the first thing you're going to do is review the history. It's always funny to me that I look at a patient's history and whatever the history says is not the actual kind of ostomy they have. So I want you to learn the terminology so that when you go in and see your patient, you can talk to the patient about what they have. Most patients that have an ostomy can't tell you what kind they have. Okay, they can tell you if urine's coming out of it or stool's coming out of it, but they really can't tell you anything else. So usually if you have a patient with a colostomy, the ostomy is going to be on the left side of the body, okay? And it's going to be usually over here. These are our most common ones, the sigmoid colostomies and the descending colostomies. You're going to see a few transverse. Those are a little bit harder to take care of usually. And then the ascending colostomy, if you happen to have a colostomy on the right side of the body, is going to be almost like your ileostomy. So these patients tend to be typically patients with a history of cancer or they've had ruptured diverticuli. Something like that is usually why you're going to have a patient with a colostomy. Some of these patients are going to have a temporary colostomy, and some of them are going to be permanent. So while we're sticking on colostomies, we're going to talk about irrigation. There are times when a patient can irrigate, or you may get an order because the patient's constipated that the doctor wants you to irrigate an ostomy. So irrigating an ostomy is a whole lot more fun than doing an enema. Okay? It really is. I'm a sick person, right? Okay. So what you're going to do when you do irrigation, first of all, you don't want to really talk to a patient about irrigation unless you know the surgeon's going to let them do it. There are some surgeons that don't like their patients to irrigate, and there's some times when a patient shouldn't irrigate. They shouldn't irrigate if they're going to be getting radiation and chemo, because they tend to have more diarrhea during those times, and you don't want to start something like that and then them have another complication. You also need to make sure you have the right equipment, and the patient needs to be able to do a lot more manipulation with their hands, and it's very time consuming. Very time consuming. So the patient needs to be able to commit to 30 minutes to an hour, either every day or every other day. And usually they're sitting in the bathroom or their bedroom, and a lot of patients don't want to do that. They don't want to take that commitment. So it's totally up to them. That's a discussion they need to have with their surgeon. So if you ever hear a patient or a doctor say, we're going to train their ostomy, okay? Irrigation is not training, okay? Basically, it's going in and cleaning that intestine out so that nothing comes out during the rest of the day. It's not a training. It's not anything like that, because they can, if they're sick or something, they'll have stuff coming out during the day. So here's my little sample ostomy, and here's an ostomy irrigation bag. So this is what your patient would put on instead of their regular ostomy bag. So they're going to attach that to their wafer, and then here's where you're going to irrigate. And the reason you use the big long bag is you're going to put in usually 500 to a liter of fluid in the bag, and you've got to have a bag big enough to put it in. If you have their normal bag, they're going to be going and emptying it every 5 minutes, and that's just not much fun for the patient. So they usually wear a bigger bag. The problem is if the patient lets this get too full, it's really, really heavy, and it might pull their wafer off. So they have to be really watchful of what's going on. So you're going to, my water guy. So he's going to hold that up. So when you're irrigating or cleaning out a patient who has an ostomy, it is possible to use some kind of Fleet's enema, but it's going to come immediately back out. So it's not effective. So if the doctor orders a Fleet's enema through their ostomy, as soon as you squirt that in, there's no rectal tone, so it's going to immediately squirt back out at you. It's not going to do any good. And that's why you get the irrigation kit with a cone. Looks just like you're going to give somebody an enema that has a cone on it. You stick this on here, and you do lubricate it first. Get you a little KY jelly. And you're not sticking this all the way in, okay? You're just putting it to the tip and holding it snugly so that when the water does go in, it doesn't come squirting back out. You want to already get their bag on though, because some does, if the patient moves, leak back out and you don't want it to get all over everything. So you do this, and then you start your water just like normal. You want to start it slow with an ostomy patient, because just like with an enema, it can cause them to cramp and be very, very uncomfortable. So then when you get done, finished with that, you're going to roll this up, and different brands have different tabs at the top. You're going to roll it up, and then you're going to sit there 30 minutes to an hour and wait for all that stuff to come back out. And then once they think that their irrigation is finished, they just take it off. Some people use a regular ostomy bag after that during the day, but most people, the reason they irrigate is because they don't like ostomy bags. So we really recommend that they put like a cap. This is an Ostomy Cap, and basically it's just almost like a little piece of gauze in there with a filter that lets the gas out, and then they can walk around with something smaller. This is paid for by insurance, I believe 30 a month.
30 a month, don't put extras,
30 a month. Okay, so those patients that irrigate, they could change these. This is also, while we're talking about it, a little privacy cap. So you have a lot of patients who want something more private during certain times of activities that they're doing. They might have a colostomy, but during maybe sexual intercourse or something else, they want something a little bit more private instead of a bag in the way. So if your patient already has a colostomy bag and their insurance is paying for this, they won't pay for something else, but I would encourage the patient if they wanted to go and buy a box, and then they would have something a little bit more private. Some people use it when they go swimming, if they want something a little bit smaller. Okay? Any questions about irrigating? I know that's a great way for y'all to start with eating your breakfast and talking about irrigation. Colostomy irrigation this morning. Okay, so now let's talk about ileostomies. Ileostomies that's the kind of ostomy I have. They are probably the most difficult ostomy to take care of. And an ileostomy patient has usually had surgery because either their colon was entirely removed for cancer, Crohn's disease, maybe their ruptured diverticuli was really, really bad, maybe some kind of traumatic event where they've had a car wreck. Sometimes their colon is still in there and they're just having a temporary ileostomy. They're going to go back and reconnect them. And with ileostomies, you need to expect that patient to empty their bag about 8 times a day. So if you work in a rehab nursing home facility, this can be an issue, okay? So what I tell my staff at our rehab and nursing home facility is as soon as that patient eats, 15 minutes later, you need to be in there checking that bag. Because what I typically see is we don't check that bag until the end of the shift, and by then it's burst. Because that's when we go around and we do our eyes and nose and things like that. That's normal. With an ileostomy patient, they have to be in there more often emptying that bag. If the patient can't tell you, they're going to burst more often and you're going to have more problems. So you need to kind of set some kind of schedule where somebody checks it right after they eat and definitely right before they go to bed. So with an ileostomy, that is part of the small intestine. Because it's part of the small intestine, that patient is going to have more liquid stools or kind of chunky or a little bit thick. And that depends on where their ileostomy is in the small intestine or what they've been eating. These patients that have a fresh ileostomy, and most of you are going to be getting patients with a fresh ileostomy, are usually going to have problems with electrolytes and dehydration. They get dehydrated very, very easily, especially in the first month after surgery. So you really want to push the fluids and watch these patients very carefully. So, ileostomies are typically on the right side. Every now and then a doctor will put it on the left because your small intestine's on both sides. So every now and then you'll see one on the left. But, you know, if they follow my instructions, they'll put it on the right side. Hopefully that doctor has done a really good ostomy and made it stick out just a little bit. Okay? You never, never, never want a flat ostomy. It's very hard for your nurse to take care of. So let's talk about a loop ostomy. Has anybody ever taken care of a loop ostomy? Okay. Loop ostomies are, when I hear, oh, my patient has a loop ostomy, I go, ooh. Yeah, they're never fun to take care of, and they're very, very complicated. Okay? And let me tell you why, first, your patient would have a loop ostomy. A surgeon typically does a loop ostomy if they're wanting to get in and out of surgery very quickly because of the patient's condition. So, to be very blunt, they may go in thinking the patient has some kind of small obstruction, and they think that they're going to do a temporary colostomy, and they go in, maybe they find a large amount of cancer. And so instead of putting the patient through a longer surgery, they do a quick loop ostomy because they know this is a bad situation. Sometimes they do loop-ostomies in patients who have trauma because the patient is very sick. They go in, they get this done, and get out very quickly. It doesn't take as long to do this type of procedure. So if you see a patient with a loop-ostomy, typically it's because the doctor chose to do it very, very quickly. So what you do with a loop-ostomy, and my husband went and bought me a little pointer last night. It doesn't work on the screen. I don't know. I guess Wendy said my dog would like my pointer, but anyway. So I'll have to point at the screen the old-fashioned way. So you go in to the belly, and they pull up an actual loop of your intestine. So it could be the large intestine, or it could be the small intestine, depending on which one they need. They pull up the actual loop, and then they stick something under it to keep it from falling back into the belly. Okay? And sometimes it's a red rubber catheter, and sometimes it's one of these white, hard plastic T-looking things. And you don't want one of those because they're hard to put bags around. And then they make a slice down the middle. They slice it, and when they slice it, then you have 2 openings. Okay? So, I know you're thinking, oh wow, that patient's in trouble. So a loop-ostomy, it can be a colostomy or an ileostomy, okay? So it might be on the right or the left side. Usually when you go in to see this patient, their ostomy is going to look really big and look really funky, and you're thinking, I don't know where the opening is. It's because they're supposed to have 2 openings, a proximal and a distal. So it should look, after surgery and everything's healed, you know, a few months later, it's going to look like this with 2 openings. But this is like a picture-perfect one. Do we ever get picture-perfect patients? No. So this is one that has a red rubber catheter threaded through it. And you can only see one opening. The other opening's on the other side. But you see where this little tube is going in right there? That's a problem. It's in the way. And you can see how hard it would be to put a bag over that. So then this is another loop-ostomy that has the little hard plastic thing. So those devices do not need to come out until the doctor takes them out. And they usually stay in the whole time the patient has the loop-ostomy. So it's very hard for the patient to learn how to pouch around that bag, around those devices. It's just something extra for those patients to learn how to do. And it's really complicated for nurses to do also. But those don't come out. That is to keep that intestine from falling back in. The problem is that you're going to have stool coming out one side. The proximal side, it means it's not which one's pointing closer to you. The proximal side is the one that's coming from the stomach and the intestines, and that's the one that's going to have the stool out of it. The distal side is the one that we're just looking at. It shouldn't have anything but mucus coming out. Now, occasionally, my patients will tell me, it has stool coming out of it too. It's probably leftover stool from surgery that's still in their colon, or it can come out one hole and kind of leak back into the other one, and so they might see stool coming out of both sides. Does anybody have any questions about this? Loop-ostomies are very common, but I don't think a lot of nurses get to see them. Okay, so let's talk about urostomies. So urostomies, of course, have urine coming out of them. But when you do your history and you're reading the history of your patient, or you're reviewing the patient to see if you're going to accept them, chances are you're going to see the term ileal conduit. Okay? And we used to only use the term ileal conduit. And I think that is very confusing for a lot of healthcare professionals. Ileostomy and ileal conduit are not the same thing. So let's talk about why it's called an ileal conduit. These patients have been through basically one big surgery and 2 surgeries put together inside that surgery. So they not only had a piece of their intestine taken out and put over here, that's the conduit. Basically, they took a piece of their small intestine and made it like a PVC pipe. Okay, so that's sewed off right there, and that's just a little piece of PVC pipe. They take out the patient's bladder, so these patients don't have a bladder. So when you go in and talk to them, don't say, oh, have you had any symptoms of bladder infection? They don't have a bladder, okay? So their kidneys drain directly into their ureters into our PVC pipe. So they not only had surgery on their urinary system, they had surgery on their gastro system. So those patients can still have the same symptoms of a patient with a bowel obstruction, a bowel resection. They can still rip open the surgery inside and have all those complications of leaky bowel and all those types of issues. Urostomy surgery is usually a little bit longer, and they usually have two surgeons, one that does the intestine and one that does the kidneys. So this ostomy is typically on the right side, and usually they look a little bit smaller. Their stoma is typically a little bit smaller. I don't know if the doctors just choose a smaller part of the intestine, but that's what you usually see. So if you've ever had a patient with a urostomy, you know that they have a lot of mucus. They have a lot of mucus because that little piece of PVC pipe makes a lot of mucus. So you'll see a lot of mucus in their bag. And then they also have a lot of infections. So they get urinary tract infections frequently. So what are the signs of a urinary tract infection in a patient that doesn't have a bladder? So they're not going to feel burning because it's not going through their urethra. So what complications are you going to see with those patients? Typically, you're going to see what you would with an elderly patient. You're going to have nausea and vomiting, achiness, flu-like symptoms. Those are the kinds of things that you're going to have with those patients. Sometimes their urine smells a whole lot worse than normal. Now, anytime you put urine in the bag, it's going to smell a little bit more anyway, but your patient may come in and say, you know what, my urine is smelling a whole lot worse today. Or their abdomen's hurting, their belly's hurting. So those are signs. So if you have your little checklist, I think a lot of the facilities now have a checklist. They don't treat you for a UTI unless you're having burning pain or frequent urination. Well, that doesn't apply to these patients. And they still need to be followed by a urologist. So if you have a patient, has anybody taken care of a urostomy patient? They're lots of fun to change the bags. So if you have a patient with urostomy and you call the doctor and say, look, they're not acting right, something's wrong, and he says, we need a urine sample. How do you get the urine sample? So back on the back wall, I printed off a copy of the Wound Ostomy Association's recommendations for how to get a sample. And if you've got one of those, if not, you can get one in a few minutes. There are two ways you can get a urine sample from a urostomy. I can tell you at our facility, the urologist only approves one way. So we're going to go first over the way that he doesn't approve of, okay? Because some of you are home health nurses, is that right? So you go out to your patient's house and the doctor wants a urine specimen and all you have is what's in your car. So what you can do, leave your wafer on if it's fairly clean. Get a normal specimen kit where you would get a clean catch on a patient with a specimen cup. And then you're going to wipe your stoma from the inside out just like you would if it was a penis, okay? Clean that off, do your little wipes, throw it away. Take your cup and set it right on the edge. Make sure you keep it as clean as possible, but then you have to stand there and wait. With a urostomy, remember there's no bladder. So if they're not making any urine right now, you're going to be standing there waiting for a while. So 15 to 20 minutes is not unusual to have to stand there and wait for a specimen. Okay? It is time consuming getting a specimen that way. We really don't recommend that method at our facility. Our urologists recommend an in and out catheter kit. So you get your little in and out catheter kit, and we use the male kind is what we like to use with our ostomies. The one that's already has the little tubing attached, if y'all have those. And you think, you want me to stick something down in your ostomy? Yes. You get urine specimens all the time, right? I promise you it's going to be okay. So that's why I want to show you what to do. So you're going to take your bag off just like normal. You're going to take your little swabs and you're gonna clean it with your little betadine, just like normal, just like you would if it was the end of a penis, okay? Clean it off, throw them away, you have your steel gloves on. You're gonna lubricate your tip, just like normal. And then when you go in, and it's a real small tube, so it should go in very easy. When you go in, you're only gonna go in about that far. Because you're just going in to this PVC pipe. And remember, the PVC pipe stops right there. So you don't want to keep jabbing them, because you're going to make them bleed. So don't keep jabbing them, just go in a little bit. Again, there's no bladder. So I know how we are when we put catheters in things. We want to see immediate urine back, right? You put a catheter in and you think, yes, I got it in, because there's urine back. Unfortunately, with this, you may not see urine back right away. 15 to 20 minutes. I waited up to 30 minutes before to get enough to fill up my specimen tube. You should see drops coming out. Now, some people you can fill up right away. But others, if they're dehydrated, it's going to take you a while to get enough to do that. I'm going to leave this up here if anybody wants to practice with later. Okay? All right. Now I lost my little foot. So we don't get our urine specimens from our urine bags, okay? So you're thinking, we have to go through all that? Why can't we just get a clean bag and put it on the patient and get it out of a clean bag? When you think about it, when you go and get a clean bag out of your supply room, isn't it in a box of 10? And how many people have stuck their hand in that box? And doesn't the box get left open in the patient's room sometimes? Those bags are not sterile. They're doing really well to be clean, right? So you cannot get an accurate specimen for a culture in that kind of situation. You never want to get it from a leg bag either, or a bedside bag for a urostomy patient. I can tell you at our facility, our urologists are very picky, and if they find out that you got the specimen out of a bag, they throw it away. Because what's going to happen is we're going to treat that patient for an infection that they probably don't have. Urostomy patients have lots of bacteria in their urine already. So they are always going to show some kind of infection if we don't get a good clean specimen. Okay, so let's talk about everybody's favorite thing to do. We love fistulas, right? Has anybody ever taken care of a patient with a fistula? Well, if you haven't, it is not fun. Those patients are very, very sick. So my goal in adding the fistula information in here basically is whenever you get an order that you're getting a patient or you're screening, to see if you're going to take a patient, you need to be aware of some things with fistula patients that are very complicated. So typically with a fistula, and a fistula is basically something that kind of looks like an ostomy, but it is an abnormal opening where the body's made its own opening between two different areas. So typically what we're going to see is an intercutaneous fistula, and that's between the gut and the skin. So they're just, by themselves, their intestines get attached to the skin and they're going to pop open an opening. They can have a high output fistula or a low output fistula. I very rarely see low output fistulas. Do you? Very rarely see low output fistulas. They're gonna put close to 1,000 liters out of their fistula a day. They're basically dumping. If you've heard of dumping syndrome, they're basically dumping. So just to show you some of the bags that are available for fistulas. Fistulas typically use something like this. This is a high output bag with a big tip on the end where thicker chunks can come through. Okay, they don't typically use urostomy bags because it won't get the thicker stuff, because fistulas are going to be stool related in this situation that we're talking about. So these are the bigger bags that we typically use for those patients. And then Jeff is going to tell you, if it's okay, how you're going to get reimbursed for that.
Reimbursement, basically, if you're in a facility, the reimbursement is not going to be there for certain items. Once these patients come out and go home, the the physician will write an order for what they believe is going to be needed per month, how many pieces will be needed. That's filed through the insurance. We're reimbursed usually about 80% rate on that, leaving about a 20% copay for the patient themselves. Depending on the type that they've ordered, with the type of adhesive, with the size of the pouch, the type of the pouch, will determine how many are allowed each month for each patient. But that's something that if they come to us for it, we'll sit down with them and let them know. Okay, if this is what's been ordered for you, you've got an extended wear adhesive, so it's going to limit the number of wafers and pouches that you can get. If it's a standard wear adhesive, if you need it, you can get more than what the standard allowable is. So it's kind of a toss-up. You really never know exactly what they're going to be allowed until we figure out what it is that's going to work for them too. So basically, a lot of times surgeons will write an order for just the basics, the standard 10 wafers a month, 20 pouches a month, barrier rings, wipes, all the accessories that go along with it. And then as we start to see what works for them, or they start to see what works for them and what doesn't, we can tweak it a little bit and get them exactly what they need to use and then file it through their insurance. So that's always been a concern for a lot of the ostomy patients that come to us is, what if I need more? Well, if you need more and the doctor can document that, then we get the insurance to cover more. So it's kind of an ongoing thing. It's never just walk in the door, day one, this is what we're prescribing you, this is what you'll use for the rest of your life. It's not that way. It's a never changing process, because a new patient coming in with a new stoma this size, in 6 months it's going to be this size, and in a year it's going to be this size. So it's always changing. It always changes. So just let any of your patients know if they have concerns about that. The main thing is going to be okay. It's going to be fine. Because most people, when they get into a bed after they've had an ostomy placed, they're thinking, I'm never leaving this bed. I'm going to die right here. I can't live the rest of my life this way. And you can't. I mean, there's a few changes to your life, but you can make it. I've done it for 10 years, so it can be done. But as far, and I just went way off the rails there.
That's okay.
But the reimbursement process is, like I said, it's nothing that's going to be set in stone from the beginning. It's going to be a pretty fluid process as we get that fluid process.
Yes, I do. And the reimbursement changes. So this year it may be one thing, and next year it may be something else. We have to be very careful with what we tell our patients are covered and what's not. Some of the things that I'm going to show you today are not covered by insurance, and that's one of the reasons Jeff is here. Because just because we like this for a patient doesn't mean it's going to be covered by their insurance. And that is one of the problems with fistulas. So if you're from a home health agency and you're bringing in a patient with a fistula, you are not going to get coverage for your fistula supplies. If the patient is going home from your rehab facility, and you think, oh, well, you know, it looks like an ostomy bag, Jeff can get reimbursement. No. For some reason, Medicare and all the wonderful insurance companies say if you have a fistula, then they will not pay for a bag. And guess what? These bags are a lot more expensive than these bags. Tremendously more expensive. So, what I want you to know about that is, well, first of all, let's go over the risk factors. The risk factors for the patient with a fistula are malnutrition, because they're dumping a lot of fluid and stool out. Dehydration, electrolyte imbalances, and I can guarantee you a fistula typically gets readmitted at least once, unless they're just a special case. They've usually been in the hospital a very long time, and they're going to get readmitted at least once. And they have a lot of skin breakdown problems around their fistulas. Okay? So, looking at these fistulas, is everybody finished with their breakfast? Okay. So, here's an example of a couple of fistulas. Typically, what you're going to see in an extreme circumstance is a wound with a fistula in the middle of it, or at the top. This one's at the top. So, you're going to see a wound with a fistula in it. And that's because the patient had a wound, and then they had a complication, and then all of a sudden they started pouring out stool out of their wound, and they developed a fistula sometime during their process. So if you go in one day and you're changing this dressing and it looks all good and healthy and everything's great, the next day you go in and there's bowel contents coming out of their belly, they've probably developed a fistula, and that's a medical emergency. You need to call a doctor about it. So what do you do in this situation? Obviously, you're not going to put an ostomy bag in the middle of this wound, right? So this is a reason why these patients take a lot of time. They're very time consuming. This one over here is multiple. I think there's 5 fistulas in the middle of this area. And the patient used to have a wound, but all that's healed up and now they just have their fistulas in there. So what are you going to do for this patient? Well, there's some fancy new things on the market. And if you want to go searching, some of the stuff you can find on the Wound Vac website, on KCI's website. So this is called a fistula crown. See? It's a fistula crown. It's only been out a couple of years. A wound ostomy nurse is the one that invented this. Okay? So basically, what you do is you measure it to the patient. I'm not going to go through every little step, but you measure it to the patient and you actually put it over the actual fistula, not over the wound. You're going to put it over the fistula, like that, and you're going to leave this little flat area on top. And then typically these patients are either going to have some kind of dry gauze dressing or a wound vac on the wound. So what the company has recommended is, of course, putting a wound vac on it. So you're doing an even longer process because you're putting a wound vac on too. So you put the wound vac on, you put your thing over your little fistula, and then you pouch over this with a regular ostomy pouch. Pouch with a regular ostomy pouch unless they're putting out a lot, and then you have to use one of your bigger pouches. And then you wound back and turn it all on. And this, being plastic, seals up real good, and it helps all that stuff down together. And you're thinking, oh my goodness, you're looking at 45 minutes to an hour. This is one reason why you need to screen your patients before you accept them. So what did I do with my other one? Oh, here it is. So this is a fistula strip, okay? So fistula strip, the lady that invented this, they said, oh, that works great, but what if I have the one on the right? This is not big enough, it wasn't helping. So then she invented this. And this basically is a strip that goes around the one, all of them together. And you can put 2 or 3 of these together if you want, but you put them together like this. And then you take and you put it on your fistula, and then you take your wound vac sponge and stick it in these little flaps, and you pouch it and wound vac the whole thing. Yeah, very complicated, but really cool, innovative things that they've come out with for some of these things. I'm gonna pass this around if y'all want to kind of play with them. Really cool, but the problem is those things are not going to be reimbursed. So what are the options for you if you're taking that patient and you're not getting reimbursed? Well, here's some examples, I'm sorry, of the pouching. So here is the foam around your little fistula strip. See how that does? Make a little bit more sense than how I described it. So if you're admitting a patient with a fistula, the number one thing you need to do is be prepared. Be prepared and know what you're accepting. Find out ahead of time what products they're needing. And if you're going to be able to afford those at your facility or with your home health agency or wherever you are, okay? If you're not going to be able to provide that for them, then you don't need to accept them as a patient. You need to tell them that this is something that you just can't handle. Or you can negotiate with the hospital can negotiate with the insurance company to say, if you take this patient, we will cover the supplies separate. So sometimes that can happen. Because if you get that patient, once you have them, then you have them, and you're trying to provide those supplies. So it's also frequent visits or frequent care for that patient. You're talking about a very time-consuming procedure. These patients do get readmitted quite often, so we're all looking at preventing readmissions. They usually have a lot of leaking, and whenever these patients leak, their stool tends to be more damaging to the skin. So they're going to have a lot more skin breakdown, a lot more complications, and typically those patients are being told what they can and cannot eat. And so in the hospital, that's really well controlled, but then when they get home, they tell them don't eat some kind of food because it's going to make your output higher. And then when they get home, you know, we all kind of break out and eat what we want to eat. And then a lot of these patients, you know, our goal with our ostomy patients is to teach them how to take care of themselves. That is my number one goal with an ostomy patient. Fistula patients are usually not going to be able to do any of this themselves, and their families aren't either. So that means that you're going to be the primary caregiver for that patient. So let's move on to actual ostomies, okay? Because fistulas don't happen very often, thank goodness. So let's move on to actual ostomies. So when you get your patient who has an ostomy, you have to do some big assessments for that patient. So let's look at this. If you have a patient with a wound and you do your assessment, you assess the wound and then you assess the skin around it, right? Same thing with an ostomy. I want you to assess the ostomy and then the skin around it. So you're going to measure size. You're going to measure shape, or not measure shape, but tell me the shape. Okay, is it oval? Unfortunately, if it's oval, it makes it a little bit more complicated. What color is it? That is a big deal. Is it pale? Is it sickly looking? Or are we having some other problems? Are there sutures present around it? Which there should be sutures around the edge if it's a brand new ostomy. Does everybody know that sutures on a brand new ostomy dissolve in about 6 weeks? They don't have to be removed. And what kind of output are you having? Is the patient having liquid? Is it thick? Is it formed? Does it vary with what the patient eats? And then what type of current appliance they're wearing. So if a nurse calls me and says, I have this ostomy patient who has a problem, these are typically the questions I'm going to ask. What are you currently trying that's not working? Because just because you have tried it doesn't mean that we're not going to try it again. Maybe the patient wasn't doing it the way you told them to do. But we do want to look at what you have tried so we don't try those same things if we don't think it's going to work. So then the peristomal skin. This is also, this peristomal skin is like one of the main reasons why you're going to have pouching problems. So when I talk to nurses, all nurses, hospital nurses, home health nurses, nursing home nurses, and I ask them about the patient, typically they're looking at the patient laying flat in the bed. Is that what you do? When you go in to change an ostomy, do you lay that patient flat in the bed? Especially at home, because there's only 2 places they can get, the recliner or the bed, right? You cannot effectively take care of your ostomy patient if they're laying flat in the bed. Now, if that patient is not participating or unable to participate, that they are a total care patient, they cannot participate, and you've assessed them sitting up and you want to lay them down and put it on, or you're having a lot of complications and you want to lay them down, that's fine. But if your goal is rehabbing that patient, sending them home, or if your goal is home health and teaching that patient, they can't learn laying down. They can't see it. And they can't learn. You can talk to them and tell them what to do, but they need to be sitting up and seeing what's going on. So I never, ever do my patients laying flat. They have to be in a sitting position, okay? So you want them in a sitting position so you can see what kind of surface they have. So are they flat? Are they lumpy? Are they wrinkled? Are they hairy? What's going on with that patient? Do they have rashes? Do they have hernias? There's all kinds of complications. Do they have a wound under there? And that's something, if you work for home health, you need to know, because if you have a wound, you need to get a diagnosis for that wound so you can get more reimbursement, right? We all want to make sure we have that. So all I'm going to do today is talk to you about the main, most common ostomy assessment problems, okay? I'm not going to talk to you about the real complicated pyodermas or anything like that. I'm going to tell you what's the most common thing you're going to walk in and see. So one of the most common things you're going to walk in and see in the first week after surgery is stoma necrosis. So if you walk in and you see this, do you know what to do? You're going to pick up the phone and call the doctor. And you're not going to wait 4 or 5 hours for him to call back. If you can't get him in that first hour, you're going to call somebody else. This is a medical emergency. This is a medical emergency. Now, If y'all like to learn names, so I'm gonna pick on Melissa, because she has her badge on. So if Melissa, where do you work?
McKinsey Healthcare.
McKinsey Healthcare, that's right. So Melissa's gonna walk in and she's gonna admit a patient. And when she walks in to admit that patient, they look like this. Hopefully that surgeon knew what they looked like before they left the hospital. But don't think that's necessarily true. This kind of thing can happen in a couple of hours. The doctor could have looked at it that morning, it's fine, and a couple hours later, their intestine is dying. Intestinal death is a medical emergency. So, you want to call and make sure this is what's been going on with that patient. In this particular situation, it's still a little wet. Sometimes the surgeon said, yeah, I know about it, it's fine, it's okay. Sometimes it's the top layer of that intestine that's dying, and it's going to slough off in the next few days. You're going to walk in there and it's going to be hanging halfway off. And that's going to slough off and it's going to bleed a little bit and everything's going to be fine. The one on the right is not. It's not going to be fine. That patient needs to go to the emergency room as quick as possible. Okay, that's a medical emergency. Typically, we see that while they're still in the hospital. But a lot of hospitals are sending patients home within the first 24 hours, 48 hours. You may see it at your facility. So the next most common thing you're going to see is mucocutaneous separation. I'm going to try not to say that again because I had trouble saying it and I definitely have trouble spelling it. So mucocutaneous separation is basically just like a wound that has dehisced. Okay? So you know what, when you go in and you see stitches, and tomorrow you go in and they've pulled open, you know, you call the doctor, they dehisced. It can happen around your stoma also because they've had surgery and stitches. So you see how the stoma stops here, and then this is all yellow and sloughy? That's because it's a wound. So now they have a wound and an ostomy. Okay, they don't just have an ostomy, they have a wound and an ostomy, and you're treating two different things under the same bag. So this is a mild case right there. And this is a pretty severe case. This patient's had quite a bit of problem. So it's almost all the way around, and it's turning a little blackish purple. So all that has pulled totally away. So we're going to talk about what you're going to do for that, but first I want you to know you're going to call the doctor and make sure they know. Okay? And what does this mean for the patient in the future? Well, typically that means they're going to develop some scar tissue around that area, which is not always good, because then they're going to have problems with pain and discomfort and possible skin problems. It also means that the patient's probably not eating. The number one cause of separation is malnutrition. So you want to really beef up that patient's nutrition. You see it a lot around people with ileostomies because they're dehydrated, their electrolytes are messed up, their liquid stool, I mean, everything's just going bad. So that's one of the things that you want to look at for those patients. So what are you going to do for that? Has anybody ever seen a patient like this? No? So what are you going to do for that? Well, I like a couple of different things in these situations. My surgeons call this angel hair, but it's not. It's calcium alginate. Does everybody know what calcium alginate is? I just use the kind in a roll for whatever brand you have. So what I typically do is take a piece, tear off or cut off what you need, kind of roll it up, and stick it in that little spot. Just like that right there. Now, why do I even care? Can I just fill it up with some paste? Some ostomy paste? Yes, you can. Ostomy paste has alcohol in it, and your patient's not going to like it because it's going to burn. But those little areas that are open are going to weep, just like a wound. They're going to drain, and that's going to make your wafer come off. So if you don't treat this with something to absorb that drainage, you're going to be changing that wafer more often. So it's better to go ahead and get something absorptive on there now. The other thing some of the doctors like is the Aquacel. You can take a piece of Aquacel and cut it and stick down in that hole. Or Hydrofiber, if you have a Hydrofiber, something, different brands are out there. So if you have another Hydrofiber type brand, something absorptive down in that area will help soak up that drainage, and then you put your bag right on top of it. So one of the mistakes that nurses make whenever they're taking care of something like this, and patients do this really badly, is they cut the opening bigger. You want to cut the opening bigger for the whole thing. That's not what we want to do when they've had a separation or a wound beside it. You want to fill up the wound with something else, but you still just want to cover it up the same size as the ostomy. Okay? So when you cut your opening, you want it to be the same size as the ostomy and cover up everything else. And the reason you do that is to keep the stool out of that wound, to try to keep them from getting an infection. I need to hang it around my neck so I can keep up with it. Okay. So this is the other more common thing you're going to see is moisture-associated skin problems. So it's the same thing as if you turn your patient over and their butt's all broke down from moisture. This is the same area. It's their rectum. It's just in the front, right? So this is an example of some severe problems. The one on the left is severe. It also has a wound around it, so it had some separation. A lot of things going on with this wound. A lot of separation around here, and basically they just ate their skin up. So do you think you're going to be able to keep an ostomy bag on this patient? Not without a lot of help. Not without a lot of help. So we're going to learn how to do that in just a second. The second thing you're going to do, the second patient you're going to see is something that's a little bit more mild, but up close is where they're having their main problem. Instead of dripping all down, they've got some up close and personal problems and then dripping down just a little bit. So what causes this? Patients not changing their wafer when it's leaking. Patients coming in and they say, oh, well, it was leaking and I didn't want to change it, so I just added some tape around the edges. Please don't do that. Because all you did was leave the stool on the skin and then stop it up to where now the stool can't get out, so it's just sitting there burning them. So adding tape around the skin after it's already leaking is wrong, okay? Sometimes it's because they're already leaking and they've been changing it, and they can't keep it on, and then their skin just keeps getting worse. So in these kinds of situations, what I would recommend is crusting. And so we're going to go over crusting in a few minutes when we start talking about supplies, okay? So the other thing you're going to see, pretty common to have after ostomy surgery, is a fungal rash. So you can get a fungal rash from anything. Remember, under an ostomy is dark and wet and warm. And so they can have a fungal rash. And sometimes, this one's pretty easy to figure out that it's a fungal rash. You see the little dots and the satellite lesions. But you can't always tell if it's a fungal rash or if they're leaking or if they're having some reaction to the supplies. Sometimes it's hard to know what's going on. And sometimes they're having all three things happen at the same time. So you have to kind of treat them as you go and see what's going on. So what do you do for a fungal rash? You do the same thing you would do if it was their bottom, except you can't use creams. Okay? So you wouldn't use nystatin cream, you would use nystatin powder. So if you put nystatin powder on, your bag's not going to stick, right? So I'm going to show you in a few minutes how to do crusting with your nystatin powder so that you can still get a patient to stick. A wafer to stick. And those patients, you want to encourage the same things you would encourage the rest of the time. You want to encourage the yogurt and buttermilk and things to help get rid of that. Probiotic, if the doctor would order it. Some of the doctors will order diflucan and some won't, so you just have to see what that doctor wants. So, you can also have peristomal injuries that are just random. Okay? The one on the right is basically skin irritation from tape. And in this situation, the description, now none of these are our patients. I get these off my wound ostomy website. But in this particular situation, they said that the patient was adding duct tape to his wafer because it wouldn't stick. So he has skin irritation from the tape that he was adding. You can have skin irritation from the tape from the wafer. And that continuous trauma of pulling that on and off is damaging to the skin. The one on the right is actually a pressure injury. You can have a pressure injury from the wafer. Maybe the patient was put in a convex wafer. Maybe they were wearing a belt that pressed into them. It's a lot of different things. The patient's sometimes puts things under there they're not supposed to, and you can have pressure or trauma from the actual appliance that the patient is wearing. So what do you do for these situations? Well, the same thing you would do for any kind of pressure injury. You want to get rid of what's causing the pressure. Now, these situations are going to leak and they're going to weep, so you want to try to dry them up. So I would use one of the two dressings that we used on this one. And then on this one, I would try very hard not to get anything on that surrounding skin. See if you can cut your wafers back or change where you're putting it so that you don't get anything on that skin and let it have some air for a little while. If you do have to have it covered, then try to minimize your chemicals and what's going on that skin. So here's the really nasty one. This is pseudo-varicose lesions, and you're not going to see this real often in a fresh patient who has just had surgery. This is typically a chronic long-term problem where the patient has not done a real good job of caring for it, or they've had too much moisture around their ostomy because their appliance is not fitting correctly. And then it just gets out of control and keeps growing. And a lot of these patients don't know that they should have called somebody. They've been living with this ostomy for years. They start having these little red bumps around the edges. These little red bumps here. And they don't know what they are. Their doctor said everything's fine, and it just keeps growing and growing and growing. And this is a severe case. So in these patients, they need medical attention. It's not an emergency. They do need medical attention, and it is going to take a while to get rid of them. So what do we do for those patients? Sometimes the doctor actually has to cut them off, and sometimes they move their ostomy. They go and have a new surgery and move it to a different spot. Sometimes they can come and see me, and I can burn them with some silver nitrate. So it kind of just depends what's going on. So here's a herniated stoma, and this is also a very common thing that you're going to see with your patients. This is the reason why you tell patients not to lift more than 10 pounds in the first couple months after surgery. Then after that, whatever the doctor tells them, they can lift. But if you have a patient that has weak abdominal muscles, then they're going to develop a hernia around the ostomy. So this one actually is herniating through the skin and around it. So if you go and see a patient, or if you've had a patient, I'm going to pick on Melissa again because I can see her name. Melissa has this patient who's been in her facility for 5 years, has had an ostomy, not having any problems. All of a sudden gets the flu, coughs a lot, coughs a lot, coughs a lot, goes in there, and all of a sudden the stoma is bigger. And she's like, I have to cut that bigger. What's going on? Or my pre-cut stuff is not working. That's when you need to say, hey, we need to see what's going on. Sometimes you can't see the hernia that well from the outside, like these two pictures. I tried to give you the worst of the worst. And I'll tell you the reason I did that. I want you to be able, when your patient takes their little stuff off and says, have you ever seen anything like this before? Your answer is, oh, I've seen much worse. Okay? That didn't mean you had to be taken care of much worse, but you've seen much worse. You're not scared of it. You're not scared of it, so you can go ahead and tell them, oh yes, I've seen much worse than this. We can handle this. Okay? That's what I want you to be able to do. Don't walk in there and go, oh my goodness, this is a nightmare. Okay? So what would you do with the one on the left? Well, this patient is having a lot of problems. They've got some skin problems here, skin irritation around it. But can you see how that hernia has made their stoma go in? So their stoma may have already been in to begin with, but the hernia building up around it can pull that skin back, and that stoma can recess. And then you have a whole world of problems because your pouching surface has changed from like this to now you have a big dip. So what they were wearing 5 years ago may not be what they can wear now. So here's another example of a recessed stoma, and this patient actually had a really bad surgery and lost a lot of weight during the surgery time, and then they got better, and after they got better, they gained weight because they got healthy again. They gained back to their normal weight, but when they did, that stoma recessed back in there because of the skin coming up around it. That stoma recessed, So they have a lot of major problems, and this picture right here, I see at least once a month, okay? Because these patients have a lot of pouching problems. You're not gonna be able to keep this bag on more than 3 days. See how much they're leaking all the way around, how white it is where it's really, really moist. So what do you do for this patient? Well, I do a lot of different things. First of all, I make sure that the patient's not cutting it bigger, because the patient is in pain. This patient is burning and hurting all the time. So when patients burn and hurt, their first thought is, I need to get that wafer off that area so it'll quit burning. And then they make the opening bigger, and when they do that, the stool sits on that skin longer, and then they burn and hurt more, and the skin gets worse. So unfortunately, you have to convince the patient that you only want the stoma showing. And you have to treat that skin. And it's not always pleasant when you do that. Pulling tape and stuff off of that skin is painful. So these patients have a big problem. Typically, I do crusting with an adhesive spray or some kind of cement on those patients to try to get it to stick more than 2 days. The longer you can get it to stick, the drier you can keep it. That patient will heal up a whole lot faster. So, has anybody seen this? Jess over here going, yes, I've seen it. Okay, this is a prolapse stoma. And I actually picked you some mild pictures, okay? I've had some really, really bad prolapse stomas. And let me tell you that if you walk in and you find a patient or you admit a patient with a prolapse stoma, you need to make sure the doctor knows, because this is not going away. Now tomorrow when you go in, the patient's laying down, they've been laying down all night, it may have fallen back in. But as soon as they sit up, start moving around, or they cough, or they bend over or do something, it's coming back out again. This is not something that we can fix. This is something that eventually the patient will have to have surgery to fix, unfortunately. In the meantime, with that being said, sometimes the doctor comes back and says, I'm not doing surgery on you anymore. That's it. We're not doing surgery unless it's an emergency. So you may be dealing with this for a while in some patients. Like if they just had surgery and the doctor doesn't think that their time is right for surgery again. So what are you going to do in this situation? So you have a wafer, and you're trying to get the wafer around this right here. And this is wet, so every time you touch it, it's getting wet stuff on the back of your wafer. So you're trying to fit this around that. Well, first of all, let me tell you what the most important thing is. Assess your stoma, okay? And don't let the patient think that you've just never seen anything like this, because you have. In this situation, typically you're going to have skin breakdown under the stoma, okay? So you need to make sure that you lift up the stoma and look to see if they have a wound under there. Not on the skin necessarily, but the actual stoma. Because typically when it does this, in that crease or bend, it rubs on either the plastic or the ostomy, and it's cutting into them. And eventually they could have a major bleed from that. So you need to make sure that the doctor knows if they're having some wounds under that stoma. And it is very hard to get a wafer on these patients. What I recommend is that you wrap it with a gauze and have either the patient hold it straight up while you clean the skin and do what you need to do. But the only way you're going to do it and keep it dry is to wrap a gauze around it while you're doing it. Okay? These patients are typically pretty scared because it's scary to see your intestines coming out their belly. If you research this on the internet, you're going to see a lot of people say, well, put some sugar on it. Yes, you can put some sugar on it and it'll shrink that swelling and it will go back in there a little bit. But it's going to come back out eventually. So the only thing that's going to permanently fix this is surgery. So when do you call the ostomy nurse? Well, you call me if you think you're having pouching problems and you've tried everything you know to do and you want me to evaluate and see if there's something I can come up with. If your wear time on your patient is less than 2 days, that's not good. If you can't get it to stay on 2 days, then hopefully we can do something that'll fix that. If they have some kind of skin breakdown and you're not comfortable taking care of it, and you call the surgeon and he's like, I don't know, or the patient says the surgeon didn't even look at it when I went to the doctor's office, you can get a referral and have them come here and let me look and see what's going on. There are many, many other wounds that a patient can have around their ostomy that are not included in the list of things I gave you today. A lot more serious type things. So you might have a patient with a learning barrier. I have some patients that come in and, I've had a patient who is blind. Patients come in with one arm and they have some learning barriers, and we can look at different ostomy supplies that might help them work through this. Jeff has lots of different options at his place of business also. We look at these catalogs all the time and we talk to the reps, and so we know some new things that are coming out on the market for those patients. Patients with the pseudovaricose lesions, they have to have some kind of treatment either by the surgeon or me to get those little moisture, the warty looking things down. And then the mucocutaneous separation, if they're really, really bad, sometimes it's deep and they've cratered, then you might want me to have a look at those patients. So when you do call me, I do need a referral from the surgeon or their primary doctor or their urologist or somebody. I do have to have a referral from them. And so what we're going to do now is talk about ostomy supplies. So if you've ever looked at an ostomy ordering book or you've ever been online trying to order ostomy supplies, it is a nightmare. There are over 1,000 different kinds of supplies. There used to be 2 or 3 major companies, and now all these smaller companies have joined in, and so there's lots and lots of different kinds of ostomy supplies. The number one thing that I don't like with ostomy patients is for a bigger hospital, usually they're the ones that do it, to send the patient home and sign them up for free supply or free samples. They sign them up for free samples from 3 different companies. And when you get the patient, you go in and look at their box and you're like, I have something from Hollister, something from Convatec, and something from Coloplast, and one of them's a urostomy and they have a colostomy, and I don't know what to do. I don't know what they wanted on this patient. Guess what? The patient doesn't know either. So if they're a home health patient and they got sent home and it leaked that first night, they don't know what to do because they have too many different things to choose from. So one of the things that your job is to go in there and say, this is what we're going to try on you first, and assure them that just because that doesn't work, that doesn't mean that there's not something else we can do. Okay? Just because I put something on a patient doesn't mean it's going to work either. So we're going to try this, and you're going to save those others in case of an emergency, but we're going to put those over there on the side, okay, so that nobody can see them and grab the wrong thing, because that can be very confusing for a patient. So we have terms like flange and pre-cut or cut to fit or flex-stend or extended wear or not extended wear, standard wear, Mios, Centura, Natura, all different kinds of things. Do you want Velcro? Do you want filters? Do you want clips? What kind of clip do you want? There's so many different kinds of ostomy supplies. So I developed this little guide a few years ago for a couple of home health agencies and some friends of mine who have trouble going through those books and trying to figure out what to do. And I thought y'all might like it. If you're not familiar with how to order ostomy supplies, this is kind of a simple guide for what convex means, what different types of bags are. This does not mean that they all come from the same company. I tried to use a couple of different styles and different companies. We don't promote one company, but we do use Hollister at our facility. So what I'm showing you mostly today is Hollister because that's what I have in my facility. But we don't necessarily